That's a great question. I'm going to preface this with this is worthy of an actual trial. This question of how you actually set PEEP, I think, is worthy of an actual trial.
Welcome back to PedsCrit. I'm Zach Hodgers, a pediatric ICU fellow from Dallas.
And I'm Alice Shanklin, a critical care fellow in Washington, D.C.
Today we have part 2 of our advanced ARDS conversation with Dr. Nadir Yehya. Remember, he is a pediatric intensivist and pediatric ARDS researcher from the Children's Hospital of Philadelphia.
Yes. And today we're going to be talking about ARDS in the intubated patient with conventional ventilation. These are the numbers we calculate at the bedside, the things we trend, the way that we choose our PEEP. Really a fantastic and clinically relevant episode for every PICU fellow.
That's right. That common scenario you find yourself at the bedside, titrating those vent settings in an intubated patient with ARDS. Let's get right to the content. So our 6-year-old with polyviral and superimposed bacterial pneumonia came up to the ICU on high-flow nasal cannula, had worsening tachypnea, worsening worker breathing, was transitioned over to BiPAP, and despite an appropriate amount of pressure in FiO2, ultimately required intubation. So you're at the bedside, you have the kid intubated, and then we'll have Alice give you your next question.
Yeah. So we're so excited to ask you about how you select your initial PEEP and what you're doing for your best PEEP trial. Because if PEEP is the independent variable, then your dependent variable could be your driving pressure. It could be the peak pressures you're needing with your volume controlled ventilation. It could be the FiO2 you land on, and it could be a true best PEEP trial where you've flipped into pressure support and you're seeing what volumes you're pulling.
Absolutely. That's a great question. I'm going to preface this with this is worthy of an actual trial. This question of how you actually set PEEP, I think, is worthy of an actual trial. The adults have 5 or 6 PEEP trials. To my knowledge, all of them have been negative of size, except for a single esophageal pressure trial, which was really the pilot trial for esophageal pressure manometry, and the validation one, EpiVent2, did not validate. So this is worthy of a trial. That being said, despite 5 or 6 negative PEEP trials, most adult practitioners operate with higher PEEP levels, which is always interesting. In pediatrics, we have a couple of different ways of setting PEEP. I set PEEP in one of 2 ways, depending on how hemodynamically stable they are and how recruitable I think their disease process is. In most patients, I do what's called an escalating PEEP trial, where I set the tidal volume at approximately 7 per kilo. Okay, but anywhere less than 8-ish or less is acceptable to me, as long as my peak pressures in decelerating flow stay less than 30 to 35. 32 plus minus 2 is kind of, I just figure being precise about these things sometimes gets a little hard to operationalize on a breath-to-breath basis, particularly with fuzzy modes like PRVC and pressure control. So 32 plus minus 2, okay? As long as you're staying below that, I will do what's called an escalating PEEP trial, where based on your initial x-ray and how difficult you were to bag, I'll guesstimate an initial starting PEEP. Okay, and then I will adjust that on my inability to wean FiO2 down to 60% or less. Okay, so if I intubate you and I think you're on PEEP at 10, and I put you on 7 per kilo and you're hitting PIPs of 25, then I will then escalate the PEEP to 12. And then I will give that about 30, 60 minutes and see how well you re-recruit. And then if that's not cutting it and you're still hypoxemic, then I'll escalate to 14. And then I'll escalate to 16 until I can get your FiO2 down to 60% or less. And if your PIPs start crawling above my PIP limits, then I start scooching down the tidal volume and potentially increasing the respiratory rate to make sure that I'm staying within a limit that is safe for pressures. I pay a lot of attention to the inspiratory and expiratory flows to make sure that they're both approaching 0. Okay, so both inspiration and expiration. Inspiratory flow going to 0 is that the pressure and volume I think I'm delivering the volume I think I'm delivering. So my numbers are accurate on the conventional ventilator. And the expiratory flows going to 0 is that they're fully exhaling and I'm not unintentionally breath stacking. This escalating PEEP strategy is relatively safe in that I shouldn't cause a pneumothorax. I shouldn't cause major cardiovascular instability. The downside of it is that it's super slow. It's super slow to recruit this way because what you're doing is every time the PIP goes up, a little bit more lung opens up. Whatever wouldn't open up at 25 might open up at 28, and now a PEEP at 12 might keep it open, okay? And conceptually, it's weird. It's weird to try to place a PEEP on the inspiratory limb and try to identify kind of a lower inflection point when the lower inflection point is an inspiratory part of the curve, whereas PEEP is end expiratory pressure. So it's conceptually weird, and it's slow, but it is safe. So in somebody who's hemodynamically bad or who I don't think is particularly recruitable, then that is the strategy I'll use. Conversely, If you told me somebody had like abdominal sepsis, okay, just systemically blew up, like a lot of non-focal diffuse pulmonary edema from like a non-pulmonary source, but as long as they're like hemodynamically like not too bad, then I actually try a different strategy. I do the exact opposite. I do what's called a decelerating PEEP strategy. And a decelerating PEEP strategy is like, I actually set the PEEP at something like 16 or 18 to start with. I recruit as much as possible. I tolerate PIPs, okay, less than like 50. And then I march down. And what that does, okay, again, setting the tidal volume around 7 per kilo or something. And then what I do is I march down. And very rapidly, what can happen there is you can get to like 25 to 30% FiO2. And then you go down to like from 18 to 16, 16 to 14, 14 to 12. And then the place at which you are going up on your FiO2 the most, and you kind of notice, okay, like there was only like a 5% FiO2 change from 14 to 12, but there was like a 20% FiO2 change from like 12 to 10. Okay, I should set this somewhere around the 12 to 14 range. All right, then I'll re-recruit again and then set it back to that. So that's a decelerating PEEP strategy. The downside of that strategy is if you're wrong, you're like super wrong. Like you can make them arrest or like cause a pneumothorax. But if you're right, then you recruit faster because now you're using much higher inspiratory pressures to recruit and much higher PEEPs to maintain their recruitment. So in somebody who's hemodynamically stable with a more diffuse, what I think of as recruitable lung, all right, then I will try a de-escalating PEEP strategy. But in most patients, I'll do what's called an escalating PEEP strategy, trying to prioritize FiO2. That gets at your second thing, okay? I'm cognizant of driving pressure. I'm cognizant of PIP and plateaus if I'm in that mode, but mostly PIP, okay? Mm-hmm. In most of the pressure-controlled decelerating flow modes that we use. I'm cognizant of those numbers, okay? But I don't prioritize them. It's actually FiO2 that I'm prioritizing while I'm keeping PIP low enough. And driving pressure just ends up being the resultant variable of me prioritizing FiO2 and keeping my PIP good enough. You see what I'm saying? But it's not like actually something I'm aiming toward. Power, I'm also aware of, but I'm not calculating toward. This is an important question that our field needs to answer moving forward. We're all getting at the idea that mechanical ventilation is intrinsically damaging. And what is the best balance of ventilator settings that adequately oxygenate and ventilate the patients versus the damage that is being caused by excessive ventilator settings? So any titrated therapy, any version of a titrated therapy where like you go up due to some things, but you go down due to side effects, like fluid boluses, for example, or pressors, okay? Ventilator settings are the same thing. They're like a version of a titrated therapy. And PEEP, if you reduce everything to PEEP as the main thing and you fix everything else, then like this is essentially a titrated therapy where like you're titrating to some effect, cognizant that at too high and at too low, okay, you're going to see problems. Either complete de-recruitment or complete overdistension and cardiac arrest from from hemodynamic issues. So you're titrating to find this area. This is probably best answered by a trial. Any number of observational studies looking at this type of thing in a titrated therapy will almost certainly give you confounded result. Okay, this is a very difficult thing to tease out from confounding by indication. Even if you have a perfect predictor, which doesn't exist, so there's no point in talking about that perfect variable to adjust for. Any degree of bias in the decision to go up or down on a therapy will lead to difficulties making inference about that from observational studies. So this absolutely needs a trial. Like, how do we set PEEP in pediatric ARDS?
Yeah, so helpful to hear your mental model using the accelerating and versus the decelerating PEEP strategy, depending on what diagnosis you're likely dealing with. In preparing for this talk, reading the ARDS literature, there's lots of suggestions to the ARDSNet PEEP FiO2 table. Do you feel like those really can apply to pediatrics? How do you think about them? How do you think your learners should use those in their practice?
The PEEP FiO2 table is a operationalized version of the escalating PEEP strategy I just described. It is a formalized, written down combination of PEEPs and FiO2, wherein if you're on 30 to 50% FiO2, your PEEPs are somewhere in the 5 to 10 range. I don't have the table in front of me, but it's approximately this sort of thing, where like if you're in the 40 to 80% range, your PEEPs in the 8 to 16 range, and if you're on 80 to 100% FiO2, your PEEP should be in the 16 to 20 range, that kind of thing. So that is effectively what we're talking about with an escalating PEEP strategy. It just gets you there a little bit more quickly, okay, by like giving you a number. So instead of going 8 to 10, 10 to 12, 12 to 14, you can say like, I'm on 80%. I'm just going to go immediately from like 8 to 16. All right, so that's all that did. And you can do that both in practice or using a PEEP FiO2 table as an approximate guidepost. The PEEP levels recommended in the low PEEP FiO2 table in 2005 when they published alveoli They tested a low PEEP FiO2 table and a high PEEP FiO2 table, and those have different matchups of PEEP and FiO2. But most PICU practitioners don't even necessarily achieve the low PEEP FiO2 table that adults would see. And there's a couple of reasons for this. So one of them is that we have access to alternative modes of ventilation. And so we're much more facile with things like the oscillator. And so like at some point, many people and many institutions historically and culturally like feel more comfortable with the same patient on an oscillator than they do on a PEEP of 18 or 20. Mm-hmm. The second reason is that like adults have a median BMI and a body habitus and abdominal contents that like actually may suggest that the pressures that they're talking about don't necessarily make it to the lung in the same way that like a baby with like compliant chest walls, less edema, different body habituses and things like that suggest that those numbers may not necessarily translate quite one-to-one. I mentioned earlier, I use my IPAP and EPAP limits the same, whether you're 1 month old or 18 years old. Okay. But I also mentioned that when I see a patient with like kyphoscoliosis, I'm willing to, make some adjustments in my head. I think you need to have that kind of flexibility where like you have some broad sense of like what kind of numbers you're comfortable dealing with, okay, with make some minor adjustments for a given patient and their particular extrathoracic processes, like either obesity or abdominal competition or things like that. And so I think you always need to be a little bit nuanced about like what actually you're delivering to the lung and disassociate that from the actual numbers that are displayed on a ventilator. Okay, because they can be very different things depending on your process. And for a specialty that sees patients between the ages of 0 and 21, okay, like you have to, I think, constantly be making adjustments for things like this and have some rule in your head, but also see like where the rules break down a little bit and maybe add or subtract a few numbers accordingly. So in pediatrics, if you're dealing with like a median age of 4 or 5 for ARDS, which I think is more accurate for our ARDS population, you're not dealing with a ton of obesity. The pressure you give is the pressure you give. And so people worry, I think, that like maybe they look at like a 50, 60-year-old and you're delivering a PIP of 30 and you're like, well, their lung is probably just seeing like, 28 or 27 or something. And you give the same baby or like a 5-year-old a PIP of 30, it's like, that's a PIP of 30. And so I think people feel that differently about PEEP as well as PIP. And so I think that is a second limitation, which makes us like err toward the lower side of things. All of that being said, an escalating PEEP strategy, while being cognizant of an upper pressure limit, you can very successfully like actually get to higher than anticipated numbers of PEEP before you like feel you have to go to another mode of ventilation. And like everything else we talk about, it's all risk versus benefit. So you're never asking the question of like, is PEEP of 16 good or bad? Okay, of course it's bad. Like, would I rather be on a PEEP of 10 or 16 if my kid was into it? No, it's like PEEP of 10, obviously, right? But if your kid needs a PEEP of 16, the question you're really asking is like, is my kid better off on a PEEP of 16 or are they better off on APRV or the oscillator? And so like you're always comparing against what your risk benefit of different things are. And we don't have hard data to get too religious about this. Like you can't be too dogmatic about stuff that we don't have data about. I think what you can say is that you have a rational approach to escalate if you've decided that you've met this failure criteria in your head of what an acceptable FiO2 or ventilator setting is. But whenever you exceed that threshold and you feel you need to escalate something, then have a framework for how you're going to escalate and what failure is going to look like. And then say like, okay, this is not cutting it. What am I going to do next?
Yeah, it's helpful. A lot of what we're talking about is lung protective modes of ventilation, or at least being lung protective in how we set our ventilators up. Much of the guidelines, when I think about reading palate guidelines, maybe some of the adult papers, they talk about keeping your plateau pressures below 28 or below 30. But when I walk around our ICU, I see a lot of PRVC, I see a lot of pressure control ventilation. I don't see plateau pressures at all. So at the bedside, how should we think about the relationship between peak pressures and plateau pressures and knowing that we are in fact being lung protective?
Yeah, no, that's a great question. So like the PARDS study, which was a multicenter, multinational point prevalence study of pediatric ARDS, had like a ton of ventilator measurements collected, like it was like 700 kids. And then like 300 or 400 of them participated in like ancillary studies in which they were documented like vent pressures every 6 hours or something like that. Less than 2% of the measurements were plateau pressures. 98% of the measurements are like peak pressures. And so like people are not looking at plateau pressures in pediatrics because we don't primarily do volume control. We do primarily pressure control or PRVC. You can certainly institute like plateau pressure as like a thing that should be monitored, but it's not currently within our workflow. So until we have a culture change where that thing that you want us to really monitor is being monitored, then you need to come up with some sort of surrogate. So about a year ago, one of our now fellows at CHOP and I published a paper in which we actually just explicitly asked this. We had a bunch of patients on their baseline vent settings, and then we flipped them into volume control and measure their plateau pressures just to see how off was PIP. And PIP is not that far off. It's usually within 2 in most measurements, and well over 95% of measurements that we took. Peak inflating pressure on PRVC or pressure control was only 2 higher than the actual plateau pressure in the correct mode of ventilation. So this has 2 implications. One implication is that when you're walking around seeing people with like PIPs of 30, you plausibly are seeing a plateau pressure of like 28 to 30. The second implication of this is that this makes complete sense when you think about like what pressures are being measured and what the definition of a plateau pressure is. In volume control, with a square flow waveform, if you have a flow that you set, because again, this is that adult mode, you have to set your flow and everything like that, match it to their inspiratory drive, 30 to 60 liters a minute is very common, and you set that flow, then that is what's going to achieve your PIP. Okay, and that component of PIP is composed of flow times resistance, right? And then the plateau pressure is when you set flow to 0. So if you set flow to 0, there's no more resistance that's being entered into that pressure equation. So all that's left is thought to be the compliance. Plateau pressure, your pressure at 0 flow. If you let your pressure control decelerating flow, your inspiratory limb go back to 0, then by definition, that pressure that ends up being read out, okay, is a pressure that's pretty close to pressure at 0 flow. So it should not be that far off from like a true plateau pressure. And in fact, it was not, only off by 2, because the machines usually overestimate a little bit, but not that much. So this makes complete sense based on what a plateau pressure is supposed to be, even in volume control. The problem is, like everything with ventilators and everything, and I'm not blaming RTs or ventilator companies for this, but it's the exact same words for very different phenomenon. Like in volume control with the square flow waveform, people call it a PIP and a plateau. In pressure control, people call it a PIP. And then you have this entire like generation of people being weaned on like, well, you can't trust the PIP. But in this other mode of ventilation, the exact same thing called the PIP, you very much can't trust. So that's annoying, but that's all that is. Annoying, right? Yeah.
Super annoying. And I'm going to push back a little bit here because our trend is volume control ventilation, usually pressure control if someone's not doing well on the volume control. When we've intubated with someone with sick lungs, the fellows do, at least on day 1, always know the plateau. Like we'll do the inspiratory hold, we'll get the plateau pressure. We talk about the static compliance pretty frequently. And I'm just reflecting on maybe it's because culturally we use volume control more. And then why is my plateau pressure in an ARDS patient? I can see what you're saying. This is Alice, coming to you from post-production. While this question and this conversation about volume control ventilation is important, I worry that I've misrepresented my institution a little bit. We don't use volume control. We use PRVC. All right, back to the episode. And in an unfortunately intubated asthmatic, where neither limbs of your lip are going to 0, your plateau pressure is so significant and so much lower.
Completely different. This only works in ARDS. Yes, this phenomenon only works in ARDS. And I should have caveated that. The degree of resistance that you find in a significant obstructive process like bad bronchiolitis or asthma, this won't work because your inspiratory limb in pressure control won't go to 0. So because it doesn't go to 0, then PIP is truly overestimating plateau by definition. Okay, because this only works if your inspiratory limb goes to 0. But ARDS has the fortune of being a fast time constant disease process. It's a primarily restrictive disease process, which if time constants are resistance times compliance, and compliance has gone down, then your time constant has gone down. It's a stiff process with fast time constants, and because it has fast time constants, inspiratory limbs tend to go to 0. Because it's like they open and close relatively quickly. And so this works because like a lot of time in the baseline I time that you set, for most patients, it works out fine. And this is why I mentioned that one of the things I pay a lot of attention to is inspiratory and expiratory flow limbs. I really like to make sure that both of them are going to 0, partly for this reason. It makes all the other measurements make sense if the machine is doing what it thinks it's doing. We talk about all of these measurements, like that PEEP is this PIP is this tidal volume is this. All of them only make sense if the thing measuring what you think you're measuring is in fact accurate. Like if I gave you an arterial line with a massive whip and an obvious whip with a non-invasive blood pressure that didn't correlate, we would all understand that there's a mistrust of some of the numbers being reported that you maybe don't need to start this patient on a blood pressure medication because you don't actually trust this because there's nothing fundamentally wrong with the line, but there's an artifact that's been introduced into what this number that is reading is measuring, right? Okay. We just get that about some devices, but all of ICU is an interaction between the patient and a lot of these monitoring devices. Okay, like pulse oxes aren't as accurate in like Black children.
Yeah.
That's an interaction between a patient and a device that wasn't particularly well thought of until we've been revisiting this problem in the last year. Okay, but like everything in the ICU, a lot of things in medicine, frankly, are like interactions between the patient and like a modality that require us to like kind of break down how accurate is this modality measuring. And that inaccuracy needs to come into our interpretation of whether we're going to act on something, particularly in things that we're going to act on.
Yeah, so very insightful. I'm curious, I mentioned earlier that we use PRVC and pressure control for nearly all of our newly intubated patients with ARDS. I'm interested in what you guys use at your prospective institutions. Alex, you mentioned volume control quite a bit. What exactly mode do you use?
Yes, volume control, but we still use pressure control, and we understand that that's likely the more effective way of ventilating these kids. So yes, we use pressure control as well, but volume control is more popular. And then we were talking about going to APRV instead of going to some of these other modes. And I'm not sure what you do in Texas or at CHOP.
Yeah, we've published various versions of this, and we're about a 75% PRVC center in ARDS.
Mm-hmm.
Nice.
Yeah, and about 25% pressure control, with a bias toward using pressure control in sicker patients, wherein the peak pressures that we start to achieve in PRVC, because you set the volume, but you monitor the pressures, even though the pressure is being delivered as a decelerating flow, the pressures start getting higher than people are comfortable with. So they switch over to a mode in which they can actually regulate the pressure directly, thinking that that might be more lung protective. Okay, but in both modes, it's decelerating flow, PRVC and pressure control. And honestly, you'd be a minority among centers in the United States if you use like square flow volume control as a primary mode of ventilation as often as you do. Yeah.
So not having the true driving pressure because you're using PRVC to...
Yeah.
Nice. So similar to your PEEP titration, there's a handful of different measurements that you can use to really operationalize, am I damaging this lung or am I not? You've got the peak inspiratory pressure, the plateau pressure, the driving pressure, and mechanical power. How do you think about interpreting these values at the bedside?
Shortest answer, PIP. In volume control modes, plateau. Longer answer. The concept we're trying to get at is this concept of stress and strain. The physics properties that we think we're messing with the most are stress and strain. All of the measurements that we're getting at are variants of surrogate markers to accurately get at the stress and the strain, thinking that if you exceed some sort of stress and or strain threshold for the lung, that is in fact going to cross you over into life-saving to potentially the risk-benefit becomes damaging more than life-saving. So that is what we're trying to avoid. The initial proposed pressure was plateau pressure as a surrogate for stress. And the idea there was that plateau pressure was like a more or less equal to transpulmonary pressure, and that's actually the stress that the lung was seeing. The strain was like potentially like the tidal volume deformation. And so maybe tidal volume should be the thing. When people did experiments of like binding rabbit lungs with, iron, and they let the pips go really high, or the pips and plateaus for that matter go really high, but the tidal volumes were relatively constrained, people started to appreciate that transpulmonary pressure, particularly when your esophageal pressure may not, or your thoracic pressure may not be zero, okay, that ends up being an important component. But for a lot of people, that's hard to operationalize with an esophageal manometer. So we just like kind of skip that and we stick with just like measured plateau pressure as a surrogate. And then people did the tidal volume trial, okay, in 2000. This drives a lot of this problem, a lot of this controversy, I should say. So the tidal volume trial, okay, compared 6 mils per kilo in adults, okay, with a plateau pressure limit of 30 against 12 milliliters per kilogram in adults with a plateau pressure limit of 50. So even in that trial, there's a problem. There's an inherent problem here. The problem is that you're testing a volume thing with a plateau limit. So some of those concepts of stress and strain are being kind of mushed together. In the 12 per kilo, you also have a much higher limit than many people were willing to tolerate. There was some controversy after ARDS was published, and people were saying that like nobody's using plateau limits of 50 and tidal volumes of 12 per kilo. And one of the responses that people gave back that had conducted the trial and like were part of the trial were like, no, what are you talking about? Plenty of people use 12 per kilo. Okay, and we like, look, this is a scatter plot of people using 12 per kilo. And the piece that's a little bit missing is that some people did use 12 per kilo when they were getting plateau pressures of like 30 to 35. But almost nobody was using 12 per kilo when your plateau pressures were in fact hitting 50. So one of the meta-criticisms of the ARMA trial, which has not really gone away in 22 years, despite 6 per kilo largely being adopted, or at least recommended, and then softened to like try to keep it less than 7 or 8, things like that, or 6.5 in adults, but like 8 in pediatrics, because we all kind of see what's happening here, is that was the control arm of 12 per kilo and a plateau pressure of 50 sabotaging that arm such that you made your control group look so bad that your 6 per kilo and a plateau limit of 30 was just better than that. But the real answer may be somewhere in the middle. So that's what's not known. But despite that, most adults have tried to keep their tidal volumes less than 6.5 per kilo in trials. Most pediatric and PALIX recommendations are keep it less than 8 per kilo for most areas, less than 6 per kilo when you become really stiff. Despite all this, like plateau pressure and PIP, okay, because as we discussed, like if your inspiratory flows are going to 0, it's not that much worse, is the most commonly discussed metric that people use to monitor this, and that is what I use to monitor this also. In the reanalysis of like 4,000 patients, which included a combination of tidal volume and PEEP trials, okay, in a reanalysis of that, the adults demonstrated in a publication in 2015 in New England Journal, one of the very few observational studies they published, by the way, it was actually the driving pressure that seemed to mediate the relationship between ventilator settings and mortality. And so if you had plateau pressures greater than 30, but your driving pressure was relatively low, okay, then you actually had low mortality. It was only when your plateau pressures exceeded 30 and you had large increases in driving pressure that you actually had increases in mortality, suggesting that the normalization of this to compliance is an important component of the actual pressure measurement. So then people said, okay, maybe we should stop looking just at plateau pressure. Maybe we should look more at the driving pressure. Okay, and that's how that became a thing. Driving pressure, unfortunately, has never been tested in a larger trial. Okay, like people have started to do pilot trials in driving pressure. Okay, but people haven't tested explicitly like driving pressure of above a damaging limit versus below a damaging limit or something like that. And the concern about residual confounding in the reanalysis remains. Okay, like even if you reanalyze 4,000 patients, okay, if your conceptual model has an unmeasured confounder, like sicker patients have less compliant lungs, okay, then all you get with a large analysis like that is a more precisely biased answer. Okay, so the concern about residual confounding in driving pressure as a concept remains, although people broadly understand that it's worse if your driving pressure is higher, but that's worse like the way that, like, of course it's worse, okay? If my FiO2 is higher, that's worse. Like that just implies that you're a sicker patient. It does not necessitate that targeting it as a parameter to target is the right thing to do or will improve outcomes. Okay, those are different concepts. So like something that's a bad prognostic value, like a high driving pressure is a bad prognostic value, may not be the same thing as targeting a lower driving pressure will improve outcomes. Those are different statements. Okay, like the number of doses of epi in CPR is associated with worse outcomes. That does not necessitate stop giving epi. All right.
Yes.
All right. So like those are different things. So that's an important thing. My concern about using driving pressure is like, am I confusing an unmeasured confounder, an epiphenomenon of severity of illness for like an actual therapeutic target? Whereas like I think plateau pressure probably has more stronger justification, and PIP, because I use decelerating flow most of the time, that has a stronger justification for being a metric to target. I think that has a stronger defense, like evidence base to defend it. Mechanical energy and mechanical power, the idea is that the damage that's being transmitted to the lung doesn't come out of nowhere. It's because like all this energy is being applied to it, and that energy is a sum of the pressures and the distension of the volume as well as the pressures that are being descended from the existing PEEP as well as the delivered tidal volume and whatever pressure distension comes with that tidal volume, okay, at a given rate. And if you do that rate, then it becomes energy times rate equals power. Okay. And so the concepts of mechanical energy and mechanical power were an attempt to provide a single unit summary variable of all of the ventilator parameters, okay, that ended up summarizing the total amount of energy that was delivered. And there's a couple of criticisms of mechanical power. One of them is an assumed linear relationship between PEEP and power, and that is probably not true. But the way that the equation is set up is that power will increase as you go from PEEP of 0 to 5 to 10, unless you have like unrealistic reductions in delta P, okay? It's probably a more like nonlinear relationship so that the linear approximations of it are probably like oversimplified. So you could end up with a biased answer there. Two, there has also never been a power trial. And so the worry is that power itself is also picking up a severity of illness marker. Okay, kids who need a respiratory rate of 20 are less sick than kids who are on the exact same ventilator settings, except a respiratory rate of 40. Like that dude clearly has worse minute ventilation. Okay, and so needs a respiratory rate of 40, not because I'm like being obnoxious about it, but because like they have sicker lungs and they have, less effective ventilation because of probably higher death base or something, right? And so that ends up being another confounder, which is not being measured in this summary, which is being captured in the summary metric. And so it again makes me worried that power and energy, end up being surrogates for severity of illness rather than being therapeutic targets. All of this can be resolved with actual trials, which look at, power 1 versus power 2, or driving pressure 1 versus driving pressure 2. And for that matter, plateau pressure 1 versus plateau pressure 2 in pediatrics. And so we can actually see whether like our thresholds are different or parallel or extrapolatable from adults, or if they're worth figuring out on our own. In terms of what I do at the bedside, and distancing itself from like the academic question, like how do we design a trial and all those things. Like what I do at the bedside is I look at the plateau pressure of the PIP because that's actually the most readily available evidence-based thing to look at to titrate a therapy to.
Yeah, that makes sense. Because you're juggling so many other variables. Mechanical power, just who's going to pull out a notebook and calculate that at the bedside?
I'm looking at the equation now because I was like, we should summarize it quick. But I think that we should not summarize it.
Yeah, that's right.
The power people argue that like any sum of things that you can figure out from ventilator pressures, you can make it, your ventilator manufacturer just make it a displayed column. And you certainly can. Yet again, it just gets back to like, is this a real thing that you should therapeutically target, or is this a epiphenomenon that like is just capturing severity of illness, right?
Sure. Yeah. Several times in our discussions thus far, you've mentioned how body habitus or maybe abdominal competition might influence your pressure that you're willing to give a patient to achieve adequate gas exchange. Any general practices that you have in using esophageal pressure monitors to help titrate your ventilatory support in patients with ARDS?
Absolutely. At CHOP right now, we don't have clinical use esophageal pressure manometers. We only have them for research use right now. Some institutions have started using this more routinely. In the mid-aughts, there was a single study in which like primarily surgical ICU population, in which you can imagine can have a fair amount of abdominal competition in adults, which you can imagine has a fair amount of obesity. Esophageal pressure is a surrogate for your thoracic pressure because your esophagus is super soft. So if you put a pressure transducer down there, and if like all the weight of like your chest wall and your belly contents causes some squishing of your thoracic pressure, that can be reflected in your esophageal pressure. And in a patient who's paralyzed, there's no spontaneous effort. And so then it's just thoracic pressure, right? As opposed to a negative deflection from them breathing. So then it's just a thoracic pressure. So if you have this thoracic pressure, all right, that you need to subtract that out to get a transpulmonary pressure. So in a patient who's like super obese, if you put their PEEP at 10, but their thoracic pressure is like 12, then you've actually set their PEEP at -2. Okay, and that's the argument. So what these people did in this pilot study was to like actually try to set their PEEP such that the delta pressure, of measured pressure minus esophageal pressure was a positive integer. And they end up using higher levels of PEEP to accomplish that, as you can imagine, in a surgical, somewhat obese adult population. So that generated a lot of interest and like, are we measuring the wrong thing? Is this prevalent enough of a problem that we actually should be subtracting this stuff out all the time? Pediatrics, different. Actually, before we even get to pediatric, the follow-up trial, in which it was a larger study, ended up not showing a significant difference, largely because their control arm used the high PEEP FiO2 table, which meant that they ended up comparing higher PEEP to higher PEEP. And so there was no difference. So that taught me two things. One, like looking at the adult population versus the pediatric population, like I don't think we have necessarily the same problems of abdominal competition or obesity at the same prevalence that the adults do. But two, this taught me that you can circumvent this by just increasing your PEEP and just running your PEEP on the higher side in patients in which you suspect that this is an issue without needing to precisely measure the exact thoracic pressure. There is precedent for this. This is similar to the PA catheter trials in the sense that like a lot of people use PA catheters, but then at some point people weren't necessarily sure, like, do I really need to shoot a Fick equation every time and like and actually figure out like the exact cardiac output? Or can I get by with some combination of ultrasound and echo? And it turned out you could. So you don't need to know the precise cardiac index of 3.3 liters per meter squared or whatever. You just need to know good enough. Okay. And between heart rate and an echo, you can figure that out, that this is good enough, or I should go up on epi. You can figure that out without knowing the precise number. Esophageal manometry is a little bit like that right now. I think it requires clarification whether it's important to know precisely that I have subtracted out my thoracic pressure, or if I can just scooch up my PEEP and PIP by like 5 or 10 and obviate that problem. I think being aware of the impact of thoracic pressure, even if you don't know the precise measurement, is important. So like if you have somebody on like conventional ventilation, your normal extubation settings are a PEEP of 5. Okay, and you have somebody with like kyphoscoliosis or obesity, you just need to know that your extubation settings may be closer to a PEEP of 10 and be comfortable with that. Okay, rather than keep trying to get them to a PEEP of 5 and be like, I can't extubate you from a PEEP of 10. And then when you kind of say like, you know what, a sedated obese teenager, maybe I should extubate you from a PEEP of 10 and just put you on BiPAP and cut your sedation half so that your own respiratory effort can re-recruit this out of it, because I'm artifactually lowering your actual PEEP to a negative number if I were to try to get you to a PEEP of 5. So I think you need to be cognizant of this concept, but whether or not esophageal pressure manometry itself will necessarily be like a necessary monitoring tool versus a luxury, I think that remains to be seen. I think as more people use NAVA, because NAVA uses a esophageal manometer to measure pressure, in that sense for a negative deflection to sync, and also where the electrode is synced with, that may end up improving the amount of times that people feel comfortable with it. Maybe they'll get better technology and it'll become a thing that becomes more routinely monitored. And who knows, like if it becomes more common and people get better at it and the technology gets better at it, this may end up being a super useful thing. And unlike a PA catheter, this is like probably relatively safe, right? And so like the least safe thing about it is that you get a wrong pressure, or like you make the wrong decisions based on it. But I think that may take a little bit of time to figure out. But that's kind of where I feel esophageal pressure manometry is right now. I think the concept of thoracic pressure artifacting your measured pressures on a ventilator is a real thing, and you need to be aware of that. But do you precisely need to know? I don't know.
The idea of changing your extubation PEEP goals is like exciting to me. It's something that I've definitely seen in clinical practice. Like, oh, she's never gonna, we're gonna extubate to BiPAP. We'll keep the PEEP at 10. It's a clean plan. You get the tube out sooner. And it seems like you could also speak to your conditioning and deconditioning goals, and that they need to be able to fight their thoracic pressure, whether they're intubated or extubated.
Yeah, and the idea is that like what we miss sometimes is that intubated patients typically have a level of sedation on them, which is kind of confounding their actual work of breathing, and it ends up worsening their thoracic pressure due to position changes. Like if you're more relaxed, you have less tone, and so more of your liver crushes your lung and increases your thoracic pressure. Whereas if you're less relaxed and you're a little bit more upright, more of your liver falls away, your overall strut of your thoracic cage is a little bit less likely to be crushed by things. So the combination of being willing to extubate at a higher threshold, which is a whole separate combo, to be honest with you. But with respect to the thoracic pressure conversation, that is a component of it, in that your thoracic pressure is exacerbated by the levels of sedation that higher ventilator settings often demand. Patients can potentially tolerate extubation from higher settings when you caveat it with the knowledge that like, I'm going to cut my sedation. And so like some of what I'm seeing, their intolerance right now may be tolerated if they're more awake, and so that's part of it. And that just gets worsened by obesity or like by like a kyphoscoliosis, right? So if you have somebody who has baseline BiPAP and is on BiPAP because of their kyphoscoliosis and now they're intubated, you kind of have to be somewhat cognizant of like what their BiPAP settings you're going to extubate them to and try to get like in that neighborhood. Okay, when you're extubating, also knowing that, okay, you're going to cut their sedation, and that combination of things may be a little bit higher than what you feel comfortable with in an otherwise healthy patient, but like maybe acceptable for this patient.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscriptpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.